everyone. You're listening to Health Affairs This Week. I'm Leslie Erdelack.
And I'm Kathleen Haddad.
And today we're catching up on some recent news out of the Centers for Medicare and Medicaid Services related to hospitals and consumers. And the way I see it, at least, Kathleen, these two stories we're focusing on, although they're pretty different, I do think they're related in the sense that they deal with the various regulatory obligations, sort of the business practices and operational issues that directly affect hospitals and ultimately the people that they serve.
I think you're right on, Leslie. The rule about rural hospitals is of interest because there's been growing concern about the closures of rural hospitals. What do we know about that?
Yeah, so CMS recently issued a proposed rule, and we can talk about that in a minute. But yeah, we've heard a lot of stories about hospitals in rural communities closing. In the last, 10 or 12 years, 75 rural hospitals closed completely, meaning that they stopped providing services altogether. There were 19 rural hospitals that closed in 2020 alone, and there were even more hospitals that had to give up offering inpatient care. People in rural communities already have fewer local healthcare providers, and this is on top of the fact that they have to travel greater distances to see them. And so these closures make it even harder to get routine and emergency medical care, which I think is scary enough to think about. But on a deeper level, these closures make healthcare inequities that many rural Americans face even worse. And we know that people in rural areas have shorter life expectancies. When a rural hospital closes, the mortality rates in those communities actually go up. There are other repercussions too. The local economy takes a big hit when all of those healthcare jobs disappear. And so there's been a lot of attention on the closures themselves, but there's also been a lot of concern too about just the viability and the solvency of the facilities that remain. And so this proposed rule from CMS stems from, that long period of hospital closures and from the notion that, something needs to change to prevent these closures from continuing to happen and making sure people have access to emergency services.
So, Leslie, what does the rule say specifically?
Okay, so there's a little bit of a backstory. And so in December 2020, Congress passed the Consolidated Appropriations Act. And so in doing this, they created a new Medicare provider type called the Rural Emergency Hospital. It's a little weedy, but this is a new designation recognized by CMS where a hospital can convert to a facility that provides 24-hour emergency services but not inpatient care. Just for some context, this is the first new rural hospital type in about 20 years. The last time we saw this was in the late 90s when critical access hospitals emerged, if you're looking for a point of comparison. And maybe just in terms of the motivation behind it, if you're wondering why Congress would sort of endorse the idea of hospitals that don't provide inpatient services, but they just focus on emergency care, you can sort of think about this as an option for rural communities that might be too small to support a full service acute care hospital, but they still have needs, that go beyond ambulatory care, outpatient care. And this new program is sort of a lifeline, particularly if you're stuck between keeping the doors to your traditional hospital open or closing them completely. In order to become a rural emergency hospital, there are certain conditions and requirements that you have to meet, and that's where the proposed rule comes in. So CMS is laying out all of these conditions and the criteria for becoming this type of healthcare provider. Basically, if you're a rural hospital with fewer than 50 beds and you think that this type of facility would meet the needs of your community, then you can submit an application to become a rural emergency hospital, but you have to abide by certain rules put out by CMS to participate in the Medicare and Medicaid programs and to demonstrate that you're able to provide high quality care. And so assuming that these conditions are met and their plans are approved, then these hospitals are then eligible to get enhanced payment for their services.
So is that the point of the rule, to address the issue of closures due to financial distress? So does the rule address the problem of financial viability significantly?
Sort of. So we know that financial distress is a big risk factor for hospitals closing. It's really expensive, as you might imagine, to run an acute care hospital. The cost structure is such that it's hard to bring in the revenue that you need. And rural areas, just given their population, you're not going to have the patient volume, and that affects whether or not you can accept payment under Medicare. And then, sort of a separate issue, many rural hospitals, and this really gets to your question, I think, but many rural hospitals are in communities where you have greater shares of poor or older residents. And so they're more likely to be covered by public insurance programs like Medicaid or Medicare. And they often reimburse these hospitals for less than the cost of providing that care. If you're a rural emergency hospital under this new plan, you become eligible for higher federal reimbursement rates, which could be beneficial potentially. The proposed rule says that CMS would pay hospitals through Medicare at sort of the standard rate plus 5%, but they would also provide a monthly facility fee that has not really been specified, and kind of the details of those payment policies still need to be worked through a separate rulemaking process. But I think, yeah, without question, it's an important part of the equation, and probably something of a deciding factor for some of these hospitals.
So what's next with the comment? Is there a comment period? And when can rural hospitals expect to actually adopt this designation and get paid for it?
So I think they can start getting paid on January 1 of next year. But with any proposed rule, there's a comment period. CMS invites comments as it develops its final policies, and those are expected to be finalized later this year. The comment period closes later in August. And as I said, the proposed payment and enrollment policies are going to be developed under separate rulemaking. So we'll, of course, want to continue to observe how that process plays out. But Kathleen, so elsewhere, in CMS, the agency started, enforcing a new price transparency rule for insurers. So kind of switching gears, what's that about?
Well, we were talking about rural hospitals needing some financial support. And in this context, in a way, we can look at it, this rule is helping consumers with financial support, because the goal is for consumers to know what they will be responsible for in terms of costs for any service that they want or need before they get it. So this rule was supposed to take effect in January, but CMS delayed enforcement until July 1st, last week. The rule requires health insurers to publish machine-readable files containing the negotiated prices that insurers pay to hospitals. So this includes the allowed amount, which is kind of a magic number because it's been guarded so secretly by insurers. It's the amount upon which insurers compute their co-payments, and then consumers need to know that so they can, if they want to know what they're going to pay. The rule applies to both in-network and out-of-network providers. And for out-of-network providers, the billed charges should be published. And as I said, this is a huge step because this information has been considered proprietary for so long.
Yeah, and on the surface, anytime I hear about price transparency, I think, this sounds like a complete game changer in terms of the way that people shop for healthcare services. And, I know enough to know it's more complicated than that. So how is this rule supposed to help consumers?
Well, right now, it really won't help consumers. What it is right now is a huge dump of data by insurers. Last Friday, I tried opening one file and I just gave up. The issue, the real point at which consumers will be helped is after private vendors take this information and make it consumer friendly. Next year, however, January 1, the rule requires insurers to publish an internet-based price comparison tool for 500 services, and that would allow consumers to receive an estimate of their cost-sharing responsibility for a specific service from a specific provider. Then on January 1, 2024, these price comparison tools must include all items and services.
Yeah, this one has been a long time coming. And for those of us who need a reminder, I mean, I think we're talking about the distinction between rules for hospitals and rules for insurers. So can you explain what prompted the former rule?
Well, if you're referring to the former rule, there is a previous rule for hospitals that hospitals should publish all of the prices that they charge to insurers and to private consumers who pay cash. This rule that applies to insurers is similar to that hospital price transparency rule. Both of these grew out of the ACA as an effort to use price transparency to contain healthcare costs. The hospital rule required hospitals to post their standard charges. As I said, the negotiated charges as well. There has been some concern about whether they're really doing that.
Have they?
Well, some have. CMS did an audit earlier this year that showed 30% compliance, 30% of hospitals. And the rest of the hospitals were entered into enforcement efforts to help them comply. There was a separate survey done by a private advocacy group that found lower compliance of 14%. And there are, the advocates are arguing that CMS has to do more to enforce the hospital transparency rule. Two hospitals in that vein, were recently fined by CMS in Georgia. One about $800,000, another about $200,000. I browsed through that enforcement action, and it's interesting. It repeatedly says, even though CMS reached out, there was no. They simply said they didn't do it. And I
Yeah,
compare that to me not turning something in I need to for work. I don't think that wouldn't work.
Yeah, I saw that. That's interesting. Why do you think we're seeing such a big push right now to help consumers? I mean, I can sort of understand why in this economy, people be more interested in sort of projecting their out-of-pocket costs, but it doesn't seem like it's been a top priority for insurers and providers until more recently.
This effort, price transparency effort, is a policy effort to try to contain cost growth in healthcare. Sherry Gleed, an economist at NYU, who most of our listeners have probably read or heard, she says this price transparency effort and these rules are a seismic shift and a middle ground between utilization management to contain costs and price regulation. I think that the best case scenario, well, I'll quote Sherry, who says that the best case scenario for this information is that it will help researchers look for better ways than price transparency to contain costs. And she says that only partly in tongue-in-cheek.
Yeah, I mean, I think just to wrap up, I think the question that looms large, is will price transparency work? And I think it's definitely worth watching to see how things evolve, particularly on the compliance side, but also to the extent that consumers are actively engaged in using this pricing information to make decisions about their healthcare. So yeah, I'm sure we'll learn a lot. But that's it for us. Thanks to our listeners, and thanks, Kathleen, for joining me.
Thank you, Leslie.
You can catch us next week. If you like this episode, leave us a review, tell a friend, subscribe to Health Affairs This Week, wherever you get your podcasts. Thanks.